Welcome to the second part of nasogastric tube insertion and feeding. I am Zhijun Guo from the Cancer Hospital of Santo University Medical College. In the first part, we have talked about how to place the entry tube safely. Now, we are going to discuss how to administer feeding through this tube. After this session, you should be able to, first, perform appropriate assessment on patients receiving entry tube feeding. Second, verbalize the steps of giving the feed. Third, explain the precautions for safe tube feeding. In clinical settings, the type, amount, and frequency of feedings are ordered by the physicians. Entry tube feeding is initiated to restore or maintain nutritional status. Tube feeding can be given continuously or intermittently. Continuous feeding is generally administered over a 24-hour period using an infusion pump, which can guarantee a constant flow rate. Intermittent feeding is to give a certain amount of enteral formula several times per day. One very common practice is bolus intermittent feeding, where we can use a syringe to deliver the formula into the stomach. Now, I will use bolus intermittent feeding as an example to show you the general procedure of providing entry tube feeding in an adult. A thorough assessment is essential for safe tube feeding. When approaching the patient, introduce ourselves and verify the patient's identity first. Next, we should look for any signs of malnutrition or dehydration. Determine the presence of bowel sounds. Inquire whether the patient is lactose intolerant or allergic to any food in the feed. We also check for problems that suggest intolerance of previous feedings. For example, delayed gastric emptying, abdominal distension, diarrhea, cramping, or constipation. If there is anything wrong, we should inform the physician. The supplies needed include 60 ml irrigating syringe, correct type and amount of feeding solution, warm drinking water, facial tissues, hand sanitizer, gauze, clean gloves, a kidney basin, and a disposable sheet. Now, let's go through the procedure of feeding. First, we recheck the patient's identity. Then we explain the procedure and reason for tube feeding to the patient to get his or her cooperation. Assist the patient to a sitting position or a fowler's position with at least 30 degrees elevation in bed. If contraindicated, a slightly elevated right side lying position is acceptable. Place a disposable sheet over patient's chest, a basin, and tissues within reach. Perform hand hygiene and put on clean gloves. As the tube could have migrated or blocked between feedings, we need to verify tube position and patency before each intermittent feeding. First, check the mark on the tube at each site. If actual tube length is exposed, the position of the tube should be questioned. Then attach a syringe to the open end of the tube and aspirate. Check the color and characteristics of the gastric contents. If applicable, test the pH of the aspirate. Gastric aspirates tend to be acidic and have a pH between 1 to 5. The pH may be as high as 6 if the patient is receiving medications to reduce gastric acid production. Aspirate gastric contents to determine residual volume. Delay or change the amount of feeding ordered if residual volume of the previous feed exceeds the specified amount. Next, return aspirated contents to the stomach to prevent electrolyte imbalance. Then flush tube before feeding with about 30 ml of warm water to lubricate the lumen of tube. Then close up the tube. Aspirate feeding formula into syringe. Connect the syringe to the tube, then advance the feed slowly at the prescribed rate. After finishing, plug the tube with 50 to 100 milliliters of warm water. This prevents future blockage by sticky formula. It is important to ensure patient comfort and safety. After each feeding, close up the feeding tube and secure it to the patient's clothes. This minimizes fouling of the tube, thus preventing discomfort and dislodgement. Assist the patient to remain sitting upright in fowler's position or in a slightly elevated right lateral position for at least 30 minutes. This facilitates digestion and prevents potential reflux and aspiration. The supplies should be disposed of appropriately. If any item is to be used, wash, rinse, and dry after each feeding. Mark dates and change the supplies including the tube according to institutional policy. Then remove and discard gloves. Perform hand hygiene. Document all relevant information. The specific information includes duration of the feeding, amount and types of fluids administered, the amount comprises the fluid and any water used for flushing. If a fluid balance record is ordered, document the volume of the formula and water given. Establish a plan to maintain oral health. After each feeding, monitor the patient closely for possible problems such as the following: intolerance of feeding, such as nausea or cramping, bowel sounds, regurgitation and feelings of fullness after feedings, weight gain or loss, bowel movements such diarrhea, constipation, skin turgor, etc. Make sure you report significant deviations to the physician. We have just gone through how to administer bolus intermittent feeding through the NG tube. This flow diagram shows you the major steps of implementation. However, for either continuous or intermittent tube feeding, we should follow some important principles. First, confirm tube position and patency before each intermittent feeding. For continuous feeding, we should do this at regular intervals at least once per shift. Check for tube dislodgement after episodes of coughing, sneezing, and vomiting. Second, before feeding, verify the expiration date of the formula and warm the ordered amount to room temperature or at 78 degrees Celsius to 40 degrees Celsius. Third, run the formula at a safe rate and in an accurate volume according to the physician's order or institutional protocol. Fourth, keep the patient sitting upright or in a slightly elevated right lateral position for at least 30 minutes after feeding. Fifth, provide patients with oral care and change the tube according to protocol. This is all for this chapter. These are the references. Thank you for joining us.